Thanks.
Thank you, Mr. Chairman. I'd like to thank the organization for this kind invitation. It's a pleasure to be here and share with you our experience with total mesorectal excision, both laparoscopically and robotically. I have to say that we don't do much open surgery for primary cancers anymore, so I am clearly not talking as an expert in that regard. But we've done several hundred robotic and laparoscopic resections, and I will show you a little bit of our experience and a little bit of our approach to the radical surgery of the rectum. If you look at the utilization of laparoscopic colorectal surgery in the United States, and this is recent data that we published this past year, what transpires is that for rectal cancer, only 7% of all laparoscopic procedures in the US are done for rectal cancer. And this is just from a national hospital database that uses codes, essentially CPT codes, ICD-9 codes, ICD-10 codes, to look at the use of laparoscopy. It doesn't tell you anything about the specifics of how it was done, whether it was hand-assisted, whether it was converted or not. So it's really a very, very small percentage of all procedures in the US, and I think in most of the Western world, that are done for rectal cancer laparoscopically. We all know that for colon cancer, there is an abundance of literature supporting the benefits of laparoscopic colectomy over open colectomy in terms of length of stay, blood loss, complications, and showing similar recurrence and survival rates. And so the conclusion of this recent meta-analysis is that it is suggested that laparoscopic surgery may be preferred to conventional open surgery for colon cancer. I would argue that it shouldn't be suggested. It is. And I think that in 2014, to do open surgery for primary colon cancer is probably not the standard of care. But rectal cancer is a different story. There are incredibly more challenges, as I'm sure most of the surgeons in the room know, when dealing with TME laparoscopically. We're dealing with a circumferential dissection in which the narrow pelvis creates a very confined space near very vital structures. We have neurovascular bundles, vessels, ureters, and so on. Margin, as we heard just now from Dr. Nagnatal, how important it is in terms of prognostic significance. And then a lot of technical issues. How do we staple? Do we come with 1 firing, 2 firing, 3 firing? Do we come at 90 degree, 45 degree? An infinite number of technical issues that drive a lot of surgeons absolutely crazy. That's why when we talk about minimal invasive rectal cancer surgery, I have to say that in my experience, pure minimal invasive procedures are very rare. Most of the time we're talking about hybrids procedure, meaning we do a little bit laparoscopically and then there is a fan and steel incision to do the TME, so it's sort of half laparoscopic, half open. There is hand-assisted, putting the hand inside and holding the camera with the other hand. Does this matter? And frankly, we didn't know until recently, and now I think we have more evidence showing that actually incisions do matter and the size of the incision is important. And this is a small study that we just actually concluded this past year, looking at our own experience, cases that were done purely minimal invasive, in this case robotic, but they could have been done laparoscopically, and cases in which it was done hybrid laparoscopic open, so mobilizing the colon laparoscopic and then making a fan and steel incision, probably size between 12, I would say, and 18 centimeters transverse, versus this group here, robotic, where the incision usually is between 4 and 7. And as you can see in this group, actually, the patients were heavier, higher BMI, a little bit older. But if you look at the length of stay, there is a difference of almost 2 days between doing a mini fan and steel and a bigger fan and steel. And if you translate that, obviously, on a nationwide scale, you can tell that this probably does have some impact. That size of the incision, even when it's relatively small, even when it's buried under the bikini line, does indeed matter. There is a lot of literature, as I'm sure all of you know, supporting the use of minimal invasive surgery for rectal cancer, going back to the seminal classic trial that was published almost 10 years ago. And what it showed, again, I think this is one of the first trials, randomized trial. What it showed is that this surgery is very difficult. The pelvis for a surgeon, the rectum, especially when dealing with heavier patient, high BMI, low tumor, is a very lonely place. 34% conversion rate, and when you look at this data with an intention to treat, they were not really able to show any differences in favor of a laparoscopic approach over open. Survival, as we know, and recurrence has been shown to be the same. This past year, I think, was an important one because it showed the first randomized clinical trial from mostly Europe, Color 2 trial, looking at laparoscopic versus open TME for rectal cancer, randomized 2-to-1. And this was the first trial that I think showed very strong data in favor of a laparoscopic approach, as you can see in terms of return of bowel function, length of stay, and oncologic parameters that were similar between laparoscopic and open. The only downside of doing the laparoscopic approach was that it took a little bit longer, but the length of stay was 1 day shorter. So you trade 1 hour or 2 in the OR for 1 day of hospital stay reduction. This trial also important because the conversion rate, and this is much later than the classic trial, dropped by almost half, so 17%. Still, however, showing that even in the hands of very experienced surgeon, that a laparoscopic TME is no easy task. There's been meta-analysis on a laparoscopic TME as early as 2006, like this one by Aziz, showing that the short-term outcomes strongly favored a laparoscopic approach. We did our own meta-analysis in 2008, looking at the oncologic outcomes at the 3 years, and we did not find any differences in terms of recurrence, survival, or margins. What we found was a significant, statistically significant lower number of lymph nodes in the laparoscopic group. That was probably a statistical aberration. We didn't know what to make of it. There's been another recent meta-analysis just published in 2010, again showing similar recurrence and survival between laparoscopic and open TME. So I think that we can say that laparoscopic TME has similar oncologic outcomes compared to open. I think there are very clear and I think important short-term benefits. However, the procedure is very challenging. There is a high conversion rate, and that's why the importance of training and volume is extremely relevant. Robotic rectal surgery, why? Well, we became interested in this to try to obviate, try to overcome some of the limitations of laparoscopic TME. The pelvis had been shown in the prostate literature to be an ideal field for robotic. It has a variety of potential benefits in terms of retraction. You have more assistance, you have more independence, you have a 3D camera with a very few downside, meaning you have no tactile feedback, so you have to use visual cues when you use the robot. The instrumentation is getting better, but until very recently was somewhat limited. And cost, as I'm sure you all know, of robotic surgery is quite substantial and clearly higher than a laparoscopic approach. Very early on, with a series of publications looking at robotic TME, what stood out was low conversion rate compared to what we knew of laparoscopic. As you see from this aggregate analysis from 3 years ago, around less than 3% conversion rate, and also the positive CRM, around 2%. So we became somewhat excited about the possibility of doing truly minimally invasive rectal surgery with no incision other than a small incision to extract the specimen, with low conversion rates and very good oncologic parameters. Our own experience, this is a case match series from our own institution looking at robotic total mesorectal excision compared to laparoscopic. We did not notice any statistically significant difference, but the number were small, either in short-term or oncologic outcomes. However, there was a trend, as you can see, toward lower conversion rate 7% in the robotic group and 22% in the laparoscopic group. What about cost? Well, cost is, as I said, a very important issue for robotic. This is a very detailed cost analysis done in Korea, and as you can see, the total hospital charges for robotic are about $5,000 higher than laparoscopic. And in this particular series, with 150 patients in both groups, they were not able to demonstrate any differences between a robot and laparoscopic assisted surgery. There's been a meta-analysis published last year from Italy, 8 comparative studies. The only benefit of robotic noted, as I mentioned, was a lower conversion rate favoring robotic surgery over laparoscopy. And indeed, if you look at the trends by indication of robotic surgery in the United States, studies we published this past year, rectal cancer is growing very rapidly, much more so than colon surgery, for which I frankly do not see any indication of robotic. However, the problems with robotic TME is that, in all honesty, most large series come from expert centers that have really devoted themselves to the development and the study of the technology, and so we cannot exclude that there is a strong bias at play, and I, for one, I'm probably guilty of that. And it is difficult to extrapolate the use of robotic for low rectal cancer to rectosigmoid cancer and colon cancer and so on. And cost, I can't say enough, is a very important issue. For this reason, together with my friend David Jane from University of Leeds, actually, several years ago, we put together this study called ROLLER, which is really the first randomized trial looking at robotic technology compared to laparoscopic technology, not just in rectal cancer, but in any field, because the urologists and gynecologists have never really evaluated the robot against laparoscopy in a randomized trial. And this study, which hopefully will conclude this year, will look at conversion as the primary endpoint, as a technical marker of surgical facility. And there will be obviously a variety of secondary endpoints, which are oncologic and functional and quality of life. And the study is accruing very well. This is how it's structured. It's centered in Leeds in England. We are the North American spoke. There is also an Asian spoke. And recruitment just as actually this past month reached 350 out of 400. And from countries, mostly from Europe, especially England and Denmark, have been remarkably generous and efficient in their accrual. And lately, the accrual numbers have actually exceeded our planned target. So the study is going very well, and we should have preliminary findings by early next year. Now, robotics, talk about a little bit of technique, how we do it. Well, for those of you who are not surgeons, the robot is this cart that sits next to the patient. There's always a surgeon at the bedside, but then there is a surgeon at the console maneuvering the joysticks, and we use conventional trocars, as you can see here. We have full access to the anus and rectum to do digital rectal examination, flexible endoscopy intraoperatively, so we're always assessing margins and making sure that we come around the tumor-bearing area in a safe and effective manner. We have a variety of instruments, as you can see here. Now we have staplers, graspers, fluorescent, so the armamentarium has really become very diverse and useful. As I said, stapling is always an issue, but we have developed a variety of techniques to overcome it. We almost always use a linear stapler articulating like this. Occasionally we do a transenal extraction, and I'll show you a couple of videos. If we can start this one. So this is a low anterior resection with colloidal anastomosis in a male patient with T3N1 rectal cancer after neoadjuvant chemoradiation therapy. As you can see, the field is very stable because the camera is being held by a robotic arm, but beyond that, it is very similar to a laparoscopic approach. The only difference is that you have 5 arms working altogether, and it's very difficult to do that in laparoscopy unless you have two very capable assistants. Here on the left side is the left hypogastric nerve. We try to use scissors, and most of the time we use cutting in a very fast manner. I think the urologists have shown us that a lot of genitourinary dysfunction comes from the excessive use of cautery and the excessive reliance on energy sources. So I have found that if you use the scissors in very short bursts and cut as you coagulate, then your dissection moves much more rapidly, and the lateral heat spread is potentially reduced. This is anterior. You saw the third arm. Now we're coming on the left side, the level of the pelvic floor, which is down here. And now we approach the anal hiatus on the pelvic diaphragm, which is there. These are the seminal vesicle. Here we're doing a digital rectal examination under vision, so we know exactly where we are in relation to the tumor. Here we are within 3 centimeters of the anal verge. Again, the anal hiatus on the left side. We can really free the puborectalis from the lower rectum if we have to gain whatever margin we need to get. Same thing on the right side here, posteriorly. And this whole field is probably 3 or 4 centimeters wide, and the camera holds extremely stable. Can you do this laparoscopically? Yes, you can. We do it. I think it's a little bit harder. It's a little bit more of a headache, and I don't think it's as safe. This is how we staple, usually with a linear stapler. Now we have a robotic stapler, so the surgeon himself can fire the stapler under his own control. And this is really the small anal stump that you can see here, getting ready for anastomosis in this male patient. And in this case, this was done with a J-pouch anal anastomosis. Can we show some of the new things that we do with the robot that I think are pretty exciting? Patients who have tumors of the mid and upper rectum, we do a lot of transanal extractions so that there is no incision. These patients go home with 6 trocars, and essentially it's like a laparoscopic cholecystectomy in terms of the abdominal wall impact. And if you can fast forward it, thank you. Most of these procedures, by the way, have a laparoscopic component and then a robotic component for the pelvis. So we always use a laparoscopic approach for the splenic flexure, as you can see here. Most of the time we divide the vessels laparoscopically. We really reserve the robot mostly for the pelvic part. This is the inferior mesenteric artery. This is actually the robotic vessel sealer, as you can see. And now we proceed with the TME, again using really only monopolar cautery. Occasionally we use bipolar. I do agree that we will be operating on fewer patients. I could not agree more with Dr. Abragama and everybody else this morning. That there is no doubt that in 5 years from now we will be operating on fewer patients than we do now. But I do think the ones where we'll operate on will be more difficult. They will be fatter, they will have bigger tumor, and they will be sicker. And I think anything we can do to reduce the impact of surgery will be tremendously beneficial. In this case, what I'm doing, I'm putting a purse string around the rectum to close off the lumen distal. We're about 5 centimeters distal to this tumor. And then we are irrigating the rectal stump, opening it with the robotic scissors. As you can see here, this is the rectal lumen. And then we will extract the specimen transanally. But before doing that, we will give fluorescent dye. You see this green? This is a compound called ICG, indocyanine green, that fluorescence at near infrared wavelength green, and it tells us where the perfect blood supply perfusion is. And one of the big problems we still have with rectal cancer surgery, as you know, I think the #1 cause of morbidity, without a doubt, is an anastomotic leak, and a lot of it has to do with pure perfusion. In 2014, most of what surgeons do around the world is just blowing air up the rectum to see if the pneumatic test is negative. That is very gross. That is 18th century stuff. So we need to do something more. As I said, having a 10% anastomotic leak rate, which is all over the literature is okay, but we can do a lot better. And hopefully this is a step in the right direction. And we have been employing this technology for the last 2 years, and so far I think the data is quite encouraging, and we have studies that are ongoing. This is the anastomosis, is done as a single staple technique. As you can see, there is no dog ears. The entire lumen of the rectum is incorporated with the colon. And again, these patients have six port sites, essentially. So I think in conclusion, what we can say is that there is no doubt the laparoscopic TME is safe and effective. I think it's superior to open surgery in terms of short-term outcomes. I don't think we have enough data to say that the robot is any better, and we may never be able to say that. A lot of what we know is very subjective and anecdotal, but clearly it's a technology that is worth looking at, and I think it's here to stay. Thank you.